Welcome to the Ending the HIV Epidemic Advisory Council meeting for January 21st, 2021. Being that we are still electronic, I'm going to go ahead and make a motion to conduct the meeting by electronic means. So I'll go ahead and make my little disclaimer. I move that the items on the meeting agenda constitute essential business of this council. Meeting electronically is necessary to protect the health, safety, and welfare of Tennesseans considering the COVID-19 outbreak and any rule conflicting with the governor's executive order 16 and 34 permitting electronic meetings to be suspended. Can I go ahead and get a second to have this meeting electronically?
Second.
Okay. All in favor?
Aye.
Okay. We're going to go ahead and do the roll call as well and make sure we have everybody on the agenda that's here. Julie, can you see these or do you need me to run down the list?
Happy to do it. Brady. And Brian seconded. I don't know that he needs to repeat that. You made the motion, so Claire.
Here, I move to approve.
We just had somebody join by phone, but I'm not sure who it is. The number ending in 53. If you can hear us, you are muted. The person who called in. I'll move on to Dr. Hildreth.
Yes, I'm here. Thanks.
And Rajiv.
Here, Julie.
And that is all of the members, council members who are present. We have the call-in number back. You might not be able to unmute yourself.
Yeah, hi, this is Amna. Good afternoon.
Hey, Amna, sorry for the...
I couldn't unmute myself. I thought I could just guess it. So I'm here. Thanks.
Right, I think that's everyone.
Okay, so in that case, we will move on to our first presentation of the day, which is about the Ending the Endemic plan that's in development for the state of Tennessee. And we have two guests with us here today to discuss that. So we have Amber Coyne, who was really integral in the preparation of this plan that we are enacting here in Nashville, and also Lindsay Sizemore from the viral hepatitis program at the Tennessee Department of Health. So I will let you all take over from here.
Hi, everyone. My name is Amber Coyne, as Claire mentioned, and I formerly used to work at the Metro Public Health Department and recognize a lot of you all from that work on the Nashville EHE plan, so it's good to see you all again. And I'm joined by Lindsay Sizemore, who is one of my bosses at the Tennessee Department of Health over the viral hepatitis program, who, because WebEx, is listed as Shannon DuPont on the participant list, just so everyone is aware. Lindsay, do you want to say anything before I jump into slides?
No, Amber, that's perfect. And again, I have no idea why I'm showing up as Shannon, and I can't change it. So I clarified in the chat box, but hi, everybody.
All right, so let me share my slides here. Can y'all see that?
Yep.
Thumbs up. Okay, great. Okay, so I'm going to talk to you guys a little bit about what the End This Endemic Tennessee initiative is, and then we'll talk about maybe some potential opportunities to overlap between the statewide End This Endemic plan and the local Nashville Ending the HIV Epidemic plan. So really, the story about how we got to the idea of creating an End This Endemic plan really started with ending the HIV epidemic planning processes, which you guys are all very familiar with. So that top map indicates where, the blue states are states that have statewide ending the HIV epidemic plans in play. The blue dots are either county or city level plans. And then the states in green are states that are in the works or in the development of creating a statewide ending the HIV epidemic plan. And you can see that there's many states, like Texas, for example, that have a statewide plan, but then also have several local plans as well. And that is going to be the case here with Tennessee. So in Tennessee, the state is green, and that's really what End This Endemic is. It's our move to make a statewide plan. And then, of course, we have 2 local ending the HIV epidemic plans already created, one that you all are working on, and then another one in Memphis and Shelby County, Memphis area. And kind of as momentum around this grew, the federal government also announced their own plan to end the HIV epidemic. And in that plan, they identified 57 jurisdictions and states that typically account for half of all new HIV diagnoses each year. And they're calling these the phase 1 jurisdictions, and those are kind of highlighted on that bottom map. And they are funding those phase 1 jurisdictions through one grant to create ending the HIV epidemic plans if they did not already have one in place. And then through a separate, very large grant are actually funding the strategies in those initiatives. So it's this really kind of large push from the federal government to actually carry out these plans. And for Tennessee, we do have one phase 1 jurisdiction, and that is in Memphis. And we expect at some point, it's been rumored since the beginning that at some point there will be a phase 2 iteration of the national plan, and that it's possible in that phase 2 that more counties in Tennessee, if not potentially the state of Tennessee, would be included in that phase 2. So we want to already have some sort of plan in place for when and if that happens. But when we started kind of thinking about creating a statewide ending the HIV epidemic plan, we kept coming back to the story of Scott County, Indiana, and their HIV hepatitis C outbreak among people who inject drugs. And for those of you that are not familiar with the story of Scott County, I'll tell you a little bit about it because it does have a lot of similarities to many of our communities in Tennessee. So it's a largely rural county with a small population of roughly 24,000 people. They have been notably impacted by high levels of poverty, unemployment, low high school graduation rates. And in the 10 years preceding 2014, they were typically diagnosing 1 to 2 new people a year in Scott County with HIV. Between November of 2014 and October of 2015, so slightly less than a year, 181 people were newly diagnosed with HIV in Scott County, and 92% of those people were also diagnosed with hepatitis C. So this was really kind of a large alarm bell for many public health officials, and they began to wonder, are there other counties in the United States that are vulnerable to this kind of rapid HIV hepatitis C outbreak, particularly among people who use drugs? And so they did a federal assessment to kind of look at vulnerability across the US. And in the federal assessment, they identified 220 counties that were highly vulnerable to this sort of event. And 41 of those 220 counties are here in Tennessee. So all of those counties are highlighted in green on that top map. The Tennessee Department of Health then kind of updated this vulnerability kind of study to use more local indicators and newer data. And in that, they found even more vulnerable counties than the federal assessment. And so that's shown on that very bottom map. Essentially here, the darker the shade of blue, the more vulnerable that county is to an HIV hepatitis C outbreak among people who inject drugs. But I think the key takeaway here is that there's no unshaded counties in Tennessee. So every county is vulnerable to some degree. So when we started thinking about, creating and ending the HIV epidemic plan for Tennessee, we realized that many of our communities that are notably impacted by HIV are also notably impacted by viral hepatitis, the sexually transmitted infection epidemics, as well as substance use disorder. And so we really started looking for frameworks that were going to speak more to this kind of interconnected challenges that we know our communities here are facing. And that's really when we came across syndemic theory. And what syndemic is it just essentially means a set of overlapping epidemics that are interconnected with each other and actually fueling each other, leading to worse health outcomes. We know that communities are facing many, many health challenges at one time. So how do you figure out what are separate epidemics versus what epidemics are actually interconnected to the degree that they're part of something larger? They're part of this larger syndemic. And the original theory for the theorist for syndemic theory, Singer, said, kind of outlined some key criteria for determining what epidemics you would include in a syndemic. The first piece of criteria is really simple. The data has to show that you have separate epidemics occurring. So the data in Tennessee tells us that we do indeed have separate HIV, viral hepatitis, substance use disorder, and STI epidemics. And when we're talking about STIs, really focusing in on chlamydia, gonorrhea, and syphilis. The second criteria is that the conditions included in a syndemic have to be connected either biologically or through some shared behavior that actually leads to worse health outcomes. So there's lots of examples of how these four health areas are connected through biology, but I'll just give you a couple of examples. One example is we know folks who have an active syphilis infection are actually more vulnerable to acquiring HIV at the site of that syphilis infection than folks who are not currently living with syphilis. We also know folks that are co-infected with HIV and hepatitis C have worse health outcomes. They are more than 3 times likely to die of liver-related diseases. So there's lots of examples of how these are intertwined biologically. We also know that these conditions are connected through shared behaviors. So one example of this is we know that sharing syringes or other equipment used to inject drugs can lead to the transmission of HIV, but it can also lead to the transmission of hepatitis C. And then the last piece of syndemic theory, and the piece that really spoke to me, is that the conditions included in the syndemic have to somehow be connected through these larger structural forces that actually are fueling the fire, right? And so we can think of these as social determinants of health. And a lot of the social determinants of health that we hear about in the context of HIV, viral hepatitis, substance use disorder, and STIs are things like homophobia, transphobia, systemic racism, poverty, lack of healthcare insurance. So these are just a few examples of that, and there's many, many more that I'm sure you all can think of. So what we want to do is create a plan that really kind of is addressing prevention and treatment across the syndemic conditions for the state of Tennessee to really guide kind of programmatic activities in the coming years. We also know, though, that what's going on in West Tennessee with each of these health areas is vastly different than what we're seeing going on in the Appalachia region or East Tennessee. So instead of making one kind of blanketed in the syndemic plan for the state, we really wanted to do regional engagement so that folks in the region could really kind of fine tune the strategies that they think would work best in their areas, and we could leverage local resources to make that happen. And we also see this as an opportunity for folks to kind of collaborate and form partnerships with other agencies in their area that are providing services that perhaps they're not able to provide under their roof, but their clients could benefit from. So for example, making sure that if someone at a substance use disorder treatment facility identifies someone that could benefit from PrEP, that they know where they can send that client to in their community to get linked up to PrEP. So we are going to be doing regional engagement, and that will be outlined in the regions indicated on the screen. So 7 regions, and of course, Nashville resides in the Mid-Cumberland region, but also includes, a lot of the surrounding counties outside of Davidson County. In terms of how we're structuring the planning process, we wanted to kind of go in alignment with the National Ending the HIV Epidemic Framework, but expand it to include these other health areas. And our reasoning for that is kind of what I stated before. We expect or anticipate at some point that there might be phase 2 jurisdictions. So we want our plan to already kind of be recognizable and lend well to sort of that structure that the federal government has kind of already outlined. So in the federal Ending the HIV Epidemic Framework, if you have not seen it, has 4 pillars, and each pillar has a goal associated with it. And then, of course, there's strategies and tactics under each one of those pillars and goals. So the 4 goals are diagnose HIV as soon as possible, treat HIV quickly and effectively among people living with HIV, protect people at risk of acquiring HIV, and respond quickly to new cases and clusters. So we are going to keep this same sort of structure, but we're changing some of the language and obviously changing the goals to really kind of speak to these other health conditions that we're including. So the first thing that we did is we reframed that diagnose pillar to be screen. One, because this kind of aligns better with the way that we talk about and think about substance use disorder, but also we want our plan to kind of adopt kind of status neutral language, right? And you know, diagnose makes it really unclear what role people not diagnosed with a particular health condition could play in ending this endemic. And we believe that all people have a role to play. Some people are going to play a role by getting involved and linked to prevention resources, and other folks to treatment resources. So we wanted to kind of make that clear from the language right up in the beginning. Don't know what this is, but I'm just going to approve it. Okay, so the goal that we are, I don't know what that is. Okay, so the goal that we're proposing for the screen pillar is increase the number of Tennessee residents comprehensively screened for HIV, sexually transmitted infections, substance use disorder, and viral hepatitis. And I'm not sure to turn off this annotation thing because it's kind of stopping me from advancing my slides. Okay, there we go. So in terms of what I see in overlap with the Nashville EHE plan and the screen pillar, we have actually already conducted some of the screen pillar meetings. So I actually am able to kind of look at what's been said in those meetings and kind of compare it to what you all have laid out in the Nashville plan. So there's a lot of overlap with the first goal and your all's plan and the screen pillar goal. So the Nashville Goal 1, ensure 90% of Nashville residents living with HIV know their sero status. And I've kind of listed out some of the strategies that you guys have in the plan that have come up in this endemic meetings, and I believe will also be residing within our plan. So one thing that came up was encouraging and implementing opt-out testing. Of course, the strategies in this endemic are, you know, talking about if someone presents to a point of care, let's say for a viral hepatitis test, that they're actually going to be screened for risk among HIV, STIs, and substance use disorder, to also then be either referred onto a substance use disorder clinical testament and receive HIV and STI testing as well. You also had in your plan about building the capacity of emergency departments to offer opt-out testing. This is something that's come up as well in our ETS meetings, but of course, again, including those other health conditions in that opt-out testing. So also including Hep C testing in that. Training healthcare providers on testing recommendations, reporting requirements, and referral services. So one of the things that we've been envisioning in these first couple of meetings for in this endemic is creating a comprehensive screening tool that really assesses for risk across the endemic conditions, that is carefully paired with some sort of decision tree or algorithm, so that providers know, like, oh, if I identify a client that potentially could benefit from PrEP, I know where to send them. Or I identified from this screening tool that my client has never been tested for hepatitis C or HIV. I don't offer that in-house, but here's where I can refer them to. And so a big piece of that conversation that we've been having is not only do we need to create a screening tool and make it practical with a decision tree and algorithm, but we also need to train providers on how to actually administer a tool like that in a way in which they feel comfortable on the provider end asking these sensitive questions and the clients feel comfortable disclosing. You also had in your plan about establishing sector-specific task force to implement HIV testing at kind of specialty places, so dental offices, primary care, and then one of the things that you had also listed was alcohol and drug service providers. So that is a direct alignment with what we're trying to do within the endemic goals, which is increase the number of substance use disorder points of care that are actually offering HIV and hepatitis C testing on site. And if they can't offer it, that they have the ability to refer folks to where they can access that testing. You also have talking about expanding community-based testing. This has also come up. And how do we kind of leverage community-based testing to make it more useful for folks? So also adding in, you know, substance use disorder screening and viral hepatitis testing as well. And then another thing that you had listed in there was about increasing access to at-home HIV testing kits. And this is something that we've been having conversations about. And, you know, is there a potential to expand, you know, at-home testing to also include self-collection for STIs and dried blood spots for hepatitis C? And then you also had in there, you know, leveraging routine hepatitis C testing that we know is going on specifically in kind of our substance use disorder facilities to really decrease stigma related to HIV testing by also adding in HIV testing into those points of care as well. And so that is, of course, in direct alignment with what we're trying to do in this endemic, which is really, you know, kind of promote opt-out testing across all health areas. The next goal is the prevent goal. We have not started prevent pillar meetings, so I can't really share key takeaways or alignments here. But the prevent goal is going to be to increase access to appropriate HIV, sexually transmitted infection, substance use disorder, and viral hepatitis prevention services in Tennessee, including harm reduction services. And what we mean by appropriate is age appropriate, culturally appropriate, and appropriate for people of that are sexually and gender diverse. For the treat pillar, increase the number of Tennessee residents linked to appropriate HIV, sexually transmitted infection, substance use disorder, and viral hepatitis treatment services. And then finally, that last pillar, which is the respond pillar, which we kind of reframe. So in the federal kind of framework, this is really about cluster detection and analysis. And we kind of wanted to reframe that and make this pillar more about how do we create sustainable ways to collaborate with agencies across this endemic health conditions. So how do we make a movement that really rolls in together all of the different community advocates and agencies that are doing work in HIV, STIs, viral hep, and substance use disorder, and really make sure that our clients are able to be navigated between these services as they need. So what are we doing in these meetings? We're starting off with providing local data about what we know is going on in this endemic through the lens of that particular pillar that we're focusing on. So for example, if we were doing the treat pillar, we'd remind them of what the goal is for the treat pillar, and then we provide illuminating evidence about what's going on. So for the treat pillar, we might provide data about the HIV continuum of care, the hepatitis C continuum of care, how many people are accessing mental health and substance abuse services in your region, how many STIs were successfully treated and cared. And then we're going to kind of discuss evidence-based strategies. So what are programs or initiatives we've seen take place in Tennessee or other places in the US actually address what the data are telling us? And some of the strategies that I am including are strategies that we have talked about and envisioned in the Nashville Ending the HIV Epidemic planning. So that's another point of alignment, kind of highlighting these strategies that you all have already identified as successful strategies. And then breaking up folks into small groups to have discussions about, what are the barriers to care in our region, both at an individual, community level, and structural level, and then what is working well, right? So we know, part of these strategies are going to be reducing or eliminating barriers, and the other part of the strategy is going to be building the capacity and expanding the things that we know actually work in our communities. Then reconvening as a large group, sharing, discussing, and reaching consensus, and then ultimately those strategies that are being identified will go into the plan. Where I see some other potential opportunities for collaboration between in this endemic and ending the HIV epidemic in Nashville is really, one, I think this is an ability for you all to kind of connect with service providers, agencies, and advocates that are working in substance use disorder, sexually transmitted infections, and viral hepatitis. So this could lead to potential partnerships where you can kind of expand maybe HIV testing or some of your other HIV initiatives. It might give you an increased advocacy base. So for example, one of the things we've been discussing in our calls related to increasing testing for HIV and viral hepatitis is modernizing the HIV viral hepatitis criminalization legislation. So many people are not aware, but the piece of legislation in play in Tennessee explicitly includes not just HIV, but also hepatitis C, and hepatitis B. So I think if more folks were aware of that, then that grows the kind of the advocacy base to really talk about that and modernize that law. Also, it'll generate more awareness about HIV outside of the HIV community by kind of folding in these other sectors. And then finally, we have identified a limited pools of funds to implement ETS pilot projects. So we'll be releasing a request for grant proposals in the next probably month or so, with the intent to hopefully fund at least one pilot project in each region. And so this is an opportunity for you all to kind of look at some of the strategies in your plan and then apply for that grant funding to actually then use it to kind of implement some of your strategies. Of course, there are stipulations in the Rfgp, being that, you know, if you're applying for the funds, you have to address at least 3 of the 4 health conditions. So you may have to adapt some of your strategies to include how would we also offer, you know, hepatitis C testing or STI testing in addition to HIV testing. But this is, you know, a potential pot of money that you guys could apply to implement some of the strategies in your plan. So that is kind of what I had. If you'd like to learn more about the project or register to attend the Mid-Cumberland meetings, I would encourage you all to check out our website, and I can type that link in the chat box, or if you use your smartphone and scan that QR code, it should take you directly there. But there you can see a calendar of upcoming meetings. We'll be posting meeting notes, information about ETS, and you can also register there. So that being said, I'm going to stop sharing and see if you guys have any questions.
Thank you so much, Amber. You know, listening to this, it strikes me that you probably, more than anybody else, are intimately familiar with both the Nashville EHE plan and the in this endemic statewide plan. And I'm just, you did a great job of laying out some of the ways that we can make sure that we're in alignment. And I'm just wondering if there's anything that sticks out to you as a particular point where we can be moving towards a project or a pilot of some kind here in Nashville that you think would be not necessarily low-hanging fruit, but something that we could sort of reach for and then hopefully expand to the rest of the state.
Yeah, so that's exactly what we're hoping comes about from the in this endemic kind of Rfgp that we'll be releasing next month. So we've kind of made it pretty nebulous in the sense that we want people to bring their own ideas to the table. So really the requirements in the Rfgp are, you know, there's a few things, but, you know, one, whatever program you are, you know, submitting to be potentially funded needs to address at least 3 of the 4 health conditions. So you could look at your plan and say, okay, we've got these strategies here that would lend well, or we could incorporate these other health areas and then come up with some sort of pilot project to actually do that. The other kind of requirements in there is, you know, that you have to kind of talk about what sort of priority populations you intend to focus on with that sort of funding. And many of the ETS priority populations are exactly the same priority populations that you all have listed in the Nashville EHE plan. So I feel like that would be quite easy for you all to lay out. And then I think there's like a few other things, but I mean, really, we're not being very prescriptive about the types of programs. We're essentially saying you need to address, your program needs to address at least one of the end this endemic goals, which as you saw are very broad. And it needs to include kind of at least 3 of the 4 health conditions. So I see that as kind of a potential thing. And then of course, you know, our hope is that people pitch us really creative projects and they go wonderfully. And then that's evidence, right, that we should expand them or find funding to kind of really take them other places or build them out.
And you may have said this and I missed it. Is there a date when this funding will, or the opportunity will be released?
Yeah, so originally we wanted to release the Rfgp. So we've already like written it out and all of that. We wanted to release it at the end of January, but that was based on the assumption that we were going to be done with all of the Prevent Pillar meetings by the end of January. But what ended up taking place is that everyone had so much to discuss on the screen pillar meetings that instead of doing prevent pillar meetings in January, we did a second round of all the screen pillar meetings. So that kind of pushed back that deadline a little bit, because I just want there to be enough ideas generated in the meetings that people have an idea of what they would want, what type of project they'd want to pitch to us. So now we're kind of thinking we're releasing that probably sometime at the end of March.
Great. And I will be quiet and let other people ask questions now.
Amber, how are you doing? This is Rajiv.
Hi, Rajiv.
So I was curious about the project. And the reason for that is, of course, thank you for having me in the Mid-Cumberland region to participate in that. But what we've been doing at Metro is that we have been looking very, very closely at an endemic project. And it's still in the early stages, but we're planning on doing a tabletop exercise at Metro, and it's going to be a syndemic related issue rather than just the epidemic. And we were also because of internal conversations about having a Scott County, Indiana type situation here in Nashville, especially since some of our counties were considered vulnerable around Davidson. We are looking at creating a tabletop exercise for Middle Tennessee. And as you know, Cindy Woodward at Hep C, Trevor Henderson in opioids, Norm Foster with HIV and STDs, along with our Ryan White program. We were hoping to, or we've started the process of kind of like putting things together. We're hoping for either in the summer or in the fall to do that program. So we are going to be working very closely with the state of Tennessee's health department. We were trying to rope in Jennifer Black, but for some weird reason, she wanted to go to Germany. We have no idea, you know. So if Shannon DuPont of the Delaware DuPonts would be happy to assist us with that, as well as you, Amber, we would be very, very happy to work with you to try to get that moving forward, you know.
Yeah, I'd love to hear about that. And then also, you know, in terms of like the syndemic, so obviously I've had people register across the state and I have ways to filter that list by region. If there's things like you guys have a tabletop exercise and you want to get the word out and it's, you know, syndemic related and you want to get it out to other partners that maybe you aren't aware of, I'm happy to send that out to people registered in the Mid-Cumberland region. And I think there's somewhere close to about 80 folks registered that come from, I think like more than like 40 organizations in the Mid-Cumberland region. So I'm happy also to disseminate the word if this is like kind of an open training opportunity or something like that.
And that's exactly what it is. And we've kind of like come up with the top. You have a series of emergency rooms in Davidson County that saw a spike of people who were coming in from overdoses of opioids. And as a result, they were doing testing at the emergency rooms and they were seeing a co-infection, an increased spike in co-infection from HIV and hepatitis. So we're seeing some sort of like syringe related intravenous drug use or kind of like a combination of things, you know, and to kind of like use that as like the starting point for our tabletop exercise. Then we could have government, we can have clinicians, we can have health, you know, all these categories of people who would be involved in the tabletop. So that's kind of like what we're looking at, and you should be hearing more about that coming up. But we would definitely be happy if Lindsay and you were involved in that. So.
Yeah, I'd love to hear more. You have my email. I can type it in the chat box again too. But yeah, definitely reach out to me and I will loop in Lindsay. But yeah, I would definitely be interested to hear more about that, and happy to help spread the word.
Steve, this is Lindsay. So yeah, thank you so much for bringing that up. Definitely want to be involved and contribute to that. And it's all coming full circle, right? Because gosh, 5 years ago now, we did our first exercise with you all at the National Metro Health Department to pilot our outbreak response plan and the related questionnaire. And honestly, like the feedback that we got from all of your staff that participated in that was so instrumental. So yes, it's full circle. We're happy to help, and we would love to be a part of it.
Thanks, Lindsay. Actually, that program 5 years ago was kind of like one of the main reasons why we wanted to start this process as well, because we felt it's been some time since we've done something like that.
And I think this sort of thinking is really starting to kind of like be talked about more widely. So the new director at over DHAP, the Division of HIV and AIDS Prevention, which actually employs me, we got the director from, many of you are familiar with him, Dr. Dimitri from the New York City Health Department, who's now the director over the CDC and is amazing. But we just had our first all hands call last week where he kind of talked about what his vision is for, taking the division, what his vision is for that. And two kind of key things were in his presentation. One, the need to really adopt status neutral language and programming across the board. And so he's like, just anticipate that anytime you talk to me about a program, I'm going to ask you, how can we make it more status neutral? And then the other piece was that he wants to take a more syndemic approach, like said the word syndemic, put up a slide with the word syndemic and like overlapping bubbles, and is, instituting regularly standing meetings with the director over the Division of Viral Hepatitis and STIs to really try to figure out more melded funding streams and more opportunities to collaborate. So I really think this is something nationally that we're going to see more of, statewide and locally, like really looking at these things together instead of separately.
Hi, this is Anna Osman with Nashville Cares. Thank you so much for the presentation. We at Nashville Cares actually have been testing for hepatitis C with no funding. And, since I've been on board in these last 2 years, pretty surprised to see the high positivity rate that has come out of that, and really helping to kind of integrate the services for those folks. And I think one of the big things that we have issues if people do test positive for hepatitis C is really finding the treatment and really linking them into care. So we just opened up in September our My House clinic, and we've been trying to really start hepatitis C treatment. But I think that's something we could really take a look at comprehensively in the region, who is available as providers to treat for hepatitis C, because testing becomes that issue when you start to test more, you find folks that are positive, but then that linkage to care piece is really critical.
Yeah,
So this is Brian Halen. I'd like to just chime in for a second on that.
Yeah.
So three quick thoughts. The first of which is Amna is raising a really important issue because of the change in the protocol around the use of fibroscans. We have been able to treat hepatitis C mono-infection at all neighborhood health locations since July of 2019, and we will continue to do that for Hep C mono infections. For Hep C HIV dual infection, the primary provider for that service, as I understand it, is still the CCC at Vanderbilt. So there is treatment, there is very robust and active treatment available for people both with mono infection and dual infection. And we're pleased to be able to offer that to people without regard to insurance or ability to pay.
Yeah, so this is something that's come up quite a bit in and I think Rajiv can probably chime in on this, but kind of the barriers to hepatitis C treatment kind of being a barrier to even folks wanting to be tested for hepatitis C. And a lot of that kind of comes down to, one, what you're talking about. Sometimes if folks are considered like a more kind of complex case, then they need to see a specialist in order to access hepatitis C treatment. So that goes for people living with HIV who are also living with hepatitis C or hepatitis B or have liver damage. They would need to see a specialist under 10 care guidelines to access hepatitis C treatment. The other barrier that's come up a lot in early meetings that we're talking through is the sobriety requirement that we know impacts a lot of folks. So needing to be meet a 6-month sobriety off of any sort of illicit substances or alcohol in order to access hepatitis C treatment. So these are conversations that we are having, and we'll put forth recommendations in the plan related to those. But you're right, there is definitely barriers to getting hepatitis C treatment, and we are aware of those. Yeah.
And I think the other one is STI, syphilis, and HIV clusters that are starting to show up. And I think kind of really finding a strategy to really work on that as we start to test more STI testing and the uptake. I mean, it's been interesting during COVID. You're seeing a lot of emergency rooms and also clinics that are finding a lot of STIs during this time. So it's been quite interesting. And then kind of those that are co-infected with HIV.
Yeah, I will say, and we've been talking about this a lot internally at Vanderbilt, is just what we're going to be dealing with as the world starts to reopen in terms of STIs, especially as we had that shortage of swabs for a while. It was difficult to even get people tested, but sex certainly has not stopped as a result of the pandemic. So we're going to be really behind on some of our goals related to HIV and STI testing, and I think it's going to be a really big concern. But I will say, in terms of the hepatitis C issue, Dr. Chastain is partially funded by the AIDS Education and Training Center and is always happy to provide clinical consultations for any healthcare providers that would like to treat Hep C in-house or Hep C HIV co-infection. He's always happy to provide guidance. We also have some really incredible pharmacists that are great at getting drugs covered, and they are also always happy to take calls and give guidance on how to sort of work that system and make sure that you're able to get medications at the lowest possible cost for your patients. So always feel free to, you can reach out to me directly if any of that would be helpful.
Yeah, thanks. And I think the last thing I want to say too is related to the social determinants that you highlighted. As we start to think of all of these, different issues that people are facing, and especially communities of color who are disproportionately affected by all of these diseases, is really the outreach, the education, and really kind of not only the testing, but also then linking them to care with culturally appropriate providers is a big issue that I think is sometimes a barrier to care and some of the determinants.
Yeah, absolutely. And that's part of when available, I've been trying to ask when I'm pulling data from the different programs, if they have data broken down by our ETS priority populations to really highlight that. And so, when I was talking about STI rates, across Tennessee, which are on the rise nationally, on the rise across Tennessee. But if you look at kind of STI rates by different subpopulations, heterosexual Black women really jump out in a lot of our STIs as being, disproportionately impacted. And I feel like that's not something we necessarily have tons of conversations about. And I personally don't see like lots of, outreach efforts kind of tailored to that community. So yeah, these are, obviously conversations that we have to have and figure out strategies to really meet the needs of communities that we're not reaching.
Any other thoughts on ETS?
Hey, Claire, this is Lindsay. I just had one kind of question for you. So I know that we've done a tremendous amount of work in the last several years with Dr. Chastain to build hepatitis C treatment capacity among primary care providers. I mean, I think, just taking a minute and pausing to just reflect on how much better we are now than we were several years ago. But something I've been wondering recently with the change in treatment to be able to treat children that are 3 and older is if there's any discussion about kind of trying to do something similar for pediatricians to treat children.
That's a good question. We haven't really discussed that yet, but it's definitely something I'll bring up with Dr. Chastain. I mean, he's not a pediatrician, but certainly I think he'd be happy to recruit someone that has more experience working with children. And, I actually honestly didn't know about that change in the recommendation, so I will find out. It's a great question.
Yeah, but just because, right now we're having such an issue even identifying these children, right? So it's like so many things have to happen. So one is we have to diagnose the mother, right? Then we have to wait for a live birth. Then we get that provisional data. Then we determine, okay, this infant was exposed to hepatitis C based on what we know, right? And then it's trying to get the infant tested. Well, right now the recommendation is to test infants at 18 months of age for antibody, or you can do RNA as early as 2 months of age. But the feedback that we're hearing, boots on the ground, is nobody wants to stick a baby, right? And so providers are wanting to wait until the infant is 18 months of age. So, okay, that's fine. But the issue with that is antibody negatives are not reportable to us. And so we don't know if it's a function of they're being tested at 18 months for antibody and they're negative, which is fantastic, and we just don't know, or if they're not being tested, right? So, I mean, I think obviously step one is we've got to get them tested and figure out, what is their status. But then once they turn 3, it's like, okay, well, if you're positive, then we need to definitely make sure that you get treatment. And then one thing that's just kind of concerning me is that these kids who are kind of in between, right? So they're not necessarily being identified as an exposure when mom was pregnant, but they have hepatitis C and they're age, 3 to 12. I feel like we're just honestly missing them. And I just, would like to get conversations going now about trying to build capacity to treat these children whenever, we're able to adequately identify them.
Yeah, that's, I think we should definitely talk offline and figure out when we can set up a time to meet with Dr. Chastain to talk about all this, but really that.
Hey, Claire, Nirav Desai or Nick Desai at Vanderbilt, he's across the hallway from you guys on the other side of Thousand Oaks.
Oh, yes, yeah. Mm-hmm.
Yeah. He's somebody that we've been dealing with quite a bit, especially he's a pediatric ID. So if somebody that you want to get in touch with, I'm sure Dr. Chastain is working with him already. So
yeah, we work with them closely on adolescent transition. So that's a good thought.
Yeah, and last thing about that, and I promise I'll be quiet. This is just like my soapbox and my passion project, right? Is because we're having to wait, we have to identify first mom, right? And then we identify that she was pregnant, and then we identify infant. And just given how much hepatitis C we have in Tennessee, like it is honestly my dream, because I feel like that's what ETS is, right? Like, number one, things that we feel like we can achieve, but also just any idea is discussed and entertained, right? And it's like, I wish we could just test all infants, regardless of mom's exposure, right? Because we're also missing those where we haven't linked them back to mom.
Yeah. Yeah, let's set up a meeting, because this is a big conversation, I think, an important one. So
yeah,
I'll
reach out later.
Sounds good.
Thank you for having us, everyone. And I put some links in the chat box for our website. And if you would like to join the Mid-Cumberland planning meetings, I'd love to have you all there. I put that link too. So thank you, everyone.
All right. Well, in that case, thank you both so much for being here today. And we will move on to our next agenda item, which is the approval of the minutes. So does anybody have any corrections to the minutes that were sent out for the last meeting? All right. There being no corrections, the minutes stand approved as read. And we can move on to some updates. So first, it seems like we have some updates coming from Tariq Smith about the PrEP Coalition. So are you on, Tariq? See him on, but maybe Tariq, are you?
I am.
There you are.
Unmuted. Can you hear me? I'm sorry, everyone. Can you hear me now?
Yep, we got you.
All right. So sorry. Happy New Year. Really quickly, pleased to report the new formation of our newly formed PrEP Coalition. Let's see. So all of us are familiar with the plan, and I think that this is really good for us because it's boots on the ground. So right now, what we've done is we have developed a small PrEP coalition right now to focus on data sharing in Metro. So the idea is that the project partners, that a lot of the project partners that are involved in the ETE have come together and agreed that there are gaps in, we all know there are lots of gaps in data, and the PrEP user data is sparse and few and far between. So what we've done is we have just submitted for a small capacity grant that will help us get up and running. Stages 1 through 3 this year, 2021, are about just simply developing the data sharing agreements between us and setting up a basic database to input and collectively share data amongst the coalition to inform best practices moving forward. So the idea here is that we will spend 2021 building capacity here in Nashville with the Metro Coalition. I believe Q2 has us up, and Julie, correct me if I'm wrong here, but I believe in Q2, we have these ambitious goals. We will be up and running and with data sharing agreements. Q3, we should be moving aggressively to establish our database and populate our database. And by Q4 of this year, we expect to be able to expand to the other coalition partners and that are here within Metro. And then the idea is that this cluster then would be, after one white paper, everyone, white paper 2021 on just the data sharing between us. And then the idea is that cluster then would be able to expand. So we hope to bring Memphis, Chattanooga, and Knoxville online respectively next year moving forward as we kind of expand this. But the basic idea is just to get everyone on the same page here. We are entertaining REDCap. I don't want to get too deep into the woods because we just are going to get kind of up and running coalition wise, but these are really good first steps for us. So I would just say we're looking good. Please, all of the panel there, look out for our data sharing agreements that will be working their way up the ladder, and be supportive. This is a good thing for us, and hopefully by the end of 2021, we will be, by the end of this year, by the middle of this year, we should be up and running and actively populating our current PrEP user database. That's about all I've got. Any questions?
Thank you, Tariq.
Hey, thank you.
I'm next, Claire. I just have a couple of quick updates, and I apologize if it grays out the screen again, but I had to look at my notes or I will forget something. So I did want to provide an update on the nominations and appointment process. So we did get the results of the survey later than I think we had originally intended, but did get them finalized a couple of weeks ago, and those nominations sent to the mayor's office for review. So, we will, I anticipate hearing an update maybe in the next month or so about the status of those. And fingers crossed we'll have the appointments made for the next meeting in March. Fast track cities. So they're given the rollout of the vaccine and just the priority that that's taken, internally in the health department, and the health department being a key partner in promoting fast track cities in partnership with the office of the mayor. I think strategically it would be a good idea for us to hold off on making that recommendation until later in the spring or maybe even early in the summer. So the leadership team, we're going to convene around that. I don't think the delay, is going to come with a great cost to us, but I did just as we had that presentation back in November and the discussion of the council members and the agreement to advance that recommendation to the mayor, I did want to make that update. And those were my quick and easy updates. And I think we asked Brady then to talk about the one nomination that you should have received in your email this month.
Yes, just I did reach out in trying to get more diverse stories and people living with HIV to the table. I worked with Sean Mark, who is an employee at Nashville Cares, but worked with him this past year when we did some lobbying on the Hill, and I was extremely impressed with this young man. He is a heterosexual white male born with HIV. And some of the stories that he brings to the table have been very eye-opening to me. And I think he brings a very unique understanding of living with HIV that I think often gets a little overlooked. But I did recommend and ask him to apply, and he did. So I'm very happy to lift up his nomination and urge you all to add him to the council. Thank you.
And so you all should expect, I'm sorry, Claire, I was just going to say, I will send out another Survey Monkey for the council members to review that nomination.
So I also want to recognize Councilmember Nancy Van Rees, who's chair of the LGBT caucus, and like to recognize her and thank her for attending and ask if you have any announcements you'd like to share.
Yes, thank you very much. And I appreciate everyone's hard work every day to make our city a beautiful place. As the chair of the LGBTQ caucus of the Metro Nashville Council, which is, I get a smile every time I say that because this is the first time we've been able to make that happen. There are 5 of us, and one of our members, council member Zach Young, indicated at our last caucus meeting that he started taking PrEP and wanted to make sure that we as a caucus provided any sort of megaphone or understanding or information that could get out to our community regarding it. And if Mr. Smith or anybody from the PrEP Coalition would like to email me to get placed on our agenda for our February 25th meeting to talk about not only what the Metro Health Department is doing with the PrEP clinic, but all of the things that are happening in our community. I think that would be fantastic. I also personally serve on the as an ambassador to the Pride Study, the pridestudy.org, PrideNet out of Stanford University, and as an ambassador to the Join All of Us research program for LGBT. And I know that there's a lot of discussion in our conversations about making sure that the questions on surveys are bringing PrEP up a little bit more intentionally. And so both as a council member, as a caucus chair, and as an individual, I want to make sure that I offer my assistance in any way is helpful, and also to stay out of the way when it's not. But if someone could email me, nancy.vanreese@nashville.gov, about getting placed on our agenda for February 25th, that'd be fantastic. Thank you.
Thank you so much. Thank you for being here today. I think with that we can move.
Claire, this is Brian Hill. We have a quick announcement, if that's okay.
Oh, sure. Yeah.
So I just really want to do a loud shout out and thank you to Sharon Hurt and to Streetworks. One of the things that we've been working with Streetworks closely on for the last 60 to 90 days has been a lot more syringe sharing that we're seeing in encampment settings among individuals experiencing homelessness. And some of that needle sharing involves people who have HIV and or hepatitis C, whose diagnoses that we've confirmed. So obviously, deeply concerned about the implications of this. We reached out to the Tennessee Department of Health to see if they would relax the prohibition around doing the syringe exchange services in park areas, and state statute restricts that in cities that size of Nashville to you can't do it within 1,000 feet of a park. And since encampments are typically in parks, that's highly problematic. We were unsuccessful with that. So what Neighborhood Health and Streetworks are going to do in partnership is we will be distributing new syringe cleaning kits to individuals, and Streetworks will continue its work to provide syringe exchange services within the limitations of the statute. Sharon has also been working with Nashville Fire and EMS to make sure that to see if they can also provide more of the syringe cleaning kits in hopes of, if people are going to share syringes because of limited supplies that they have, that they're doing so as safely as possible, and that we've really embraced a harm reduction approach. So tremendous thank you to Sharon for her work in championing that.
Awesome. It's great to hear about partnerships like that. All right. Well, I think with that, we can move on to our discussion. Dr. Bullock, I don't know if you want to kick us off here.
Yeah, happy to do so. Thanks to everybody for joining us. We've had some really robust discussion this meeting. And as we look forward, we want to talk about what the Advisory Council looks like for 2021. I don't think anybody thought that we would have one meeting and then kind of go virtual, but here we are a year later. So as we look forward to 2021, we want to just kind of look back and review kind of what our responsibility and authority was, and kind of put out some of the points that we worked on, some of the progress we made, and talk about where we want to go. Probably the first thing we looked at, we were talking about guiding the implementation of the Ending the Epidemic Plan for Nashville, and including the prioritization and recommendations. We did complete the prioritization, and work groups are being formed to in response to looking at what these priorities may be. The second thing we wanted to do was ensuring that principles of health equity and social justice were incorporated in the process, and that the goals, objectives, and action steps did involve conscious efforts to reach communities that are disproportionately affected by HIV. We established a work group early in 2019. That work group has created the definition of radical inclusion. We've drafted the nominations and recruitment plan that was adopted by this council that frame the inclusion, and currently working on an equity lens to apply to the EHE work. Two additional points. We want to continue to work to ensure that institutions create, manage, and distribute the resources that directly impact the Nashville communities, understanding the responsibility of ensuring equitable resource allocation. I think we've had some really good discussion about what that looks like potentially going forward today as well. And then our fourth point would be establishing strategic priorities and mobilizing collaborative and effective community initiatives to achieve the goals and objectives of the council and the plan. So obviously that is more work to be done, especially with the last two, but I think we've made some great steps in doing that. So just kind of as we talk about and move into the discussion about what this may look like, maybe just some questions that we want to toss around and think about what we want to discuss. Kind of what were your biggest points as you look back on the council over the last year? What are kind of the things that you recall? What stands out? What has gone well? The things that on top of not going well, or potentially where do you see room for improvement in some of the items that we want to address? Where should we focus the majority of our time as a council? Is our focus in the right place? Should we focus less on certain areas and focus more on things that we feel like we can be more productive and more successful at, more of the low-hanging fruit? And then any specific agenda items that anybody on this meeting would like covered in our agenda for 2021 as we move forward. We're still on a quarterly meeting, but I think as we, being at the beginning of the year, as we plan throughout the year, we can have kind of strategically figure out where these things go. So I'm going to open it up just for some discussion. Any recommendations, suggestions, just kind of a big roundtable for everybody to kind of put out their ideas, where they want to see this go, where we can best utilize some of our time and resources as a council. And I think, Julie, you have the just the bullet points up as well. Any thoughts, suggestions?
This is Anna. Go ahead.
Oh, sorry, go ahead.
I think that, it's been hard with COVID, and us being virtual to really work on things, but I think you said it well. We've done a lot of great things. I think what I would like us to really focus on is to really start to think about the low-hanging fruit of kind of how can we, in those 4 pillars, start to find ways that we can really collectively see the impact of the services that are being provided to really move us to ending the HIV epidemic. And then really thinking about, I think with COVID, something that really became illuminated was the challenges of certain clients, and especially those of communities of color that did not have access to services due to, connectivity, and really being able to use this virtual platform from telehealth to really engaging in prevention and the screening, and then the linkage to care and retention and care. So really thinking about, how have we been doing and how do we think about that moving forward to really fulfill the goals of the ETE plan is going to be really critical as we move into the future. And really looking at that coordinated effort. I mean, we talk about PrEP, which is great, but the uptake of PrEP in communities of color, same gender loving folks is not as high as it is with, white folks. And so just really looking at that. And I think also the issue around diversity, equity, and inclusion and that racial justice piece is to really start to think how we infuse that into the plan. It's going to be something I think critical moving into this next year.
Thank you. Great points. And anybody else?
I'd love to see a greater outreach to the HIV community, to those living with HIV, to be more involved. I know that a lot of the people that I talk to on one-on-one conversations or through Facebook Messenger, Instagram, so many people are asking me, how can they be involved? But they're also at the same time scared of the stigma. So if we could come up with some kind of packet or encourage more understanding of how to advocate, on a state level, on a federal level, on a local level, engaging city government, things of that matter, because we want to be part of the solution, instead of always being, and not always, but instead of being kind of placed as the population that we have to protect everybody from. My community is really one that wants to be part of the solution. So I think, just more engagement and offering those of us living with HIV an opportunity to step up and help more.
Thank you. So you're saying really more on a strategic level to have everybody more engaged.
Correct. Health literacy is an issue, and understanding, how even, the CDC, HRSA, SAMHSA, how do all of these different organizations, how do they work with one another? Being able to utilize, everyone has different skill sets in their wheelhouse. How can, someone, anybody, like if I was a graphic designer, how can I help? But a lot of people just think that they don't, because they haven't been engaged or approached. They don't know who to go to, and how to kind of foster their own skills that they have to bring to the table.
Do we feel like we have the right resources in the communities that are more disproportionately affected? Do we feel like there's some opportunity to do some things differently within those communities to get better engagement, not necessarily on a strategic level, but just in terms of getting participation from their standpoint? Do we feel like does anybody have any ideas around that?
I mean, I think that I agree with Brady that really looking at ways of engaging people living with HIV, but just really how do we share what's going on to folks that are, as you said, who are disproportionately affected in ways that can be valuable. I know Nashville Cares, one of our major focus is communities of color and those that are disproportionately affected, and trying to really engage them not only in services, but trying to really work on, advocacy level. We did have and this is going to be one of my announcements, we are responsible for the Tennessee Advocacy Network, the AIDS Advocacy Network, and we're kind of re-engaging that. We had some staffing changes, but that's kind of going to be started up. So I think that would really start to engage people living with HIV on really the things that you highlighted, Brady, of how do we really engage them, but just really at the service level of how do we coordinate our resources to really be able to reach those that, are disproportionately affected and really need the services and have barriers, and, the social determinants are real, and especially with COVID right now, it's really difficult for people to be able to access the needed services because they can't come to the brick and mortars. And trying to really receive services virtually, we found that to be a huge challenge until we needed to find innovative ways to get people devices and train them and educate them on how to use these virtual platforms so they could really access services throughout the continuum.
Anybody else have anything additional they want to add? Do we feel like we're spending our time in the right places? Do we feel like we need to rebalance where we're taking our focus? Maybe something we're spending, I think we talked about some good opportunities where to focus more. Do we feel like there's something that we're spending too much time on that we could maybe shift a little? Okay. I think that's pretty much everything I have. Claire, do you want to add anything additional, or Julie?
I will say from my standpoint, just this is the one time I know that the bandwidth of the council members during COVID, especially, I'm looking at you, Dr. Bullock, I'm looking at you, Dr. Hildreth, but I know all of the council members' bandwidth is very limited. And so, wanting to make sure that these meetings continue to be a good use of your time. And if you think of things, improvements that can be made to the agenda after meetings. I do know that this is the time where we have the key decision makers in the room once every 2 months for an hour and a half. And so I do want to be strategic about how we use your time. So I want to continue to keep that conversation open, you know, as we move forward. But I do think the council members provided some really good ideas for next steps. Particularly, I have an idea around digital access and literacy that could be a good March agenda item for the council to think strategically about. So, and Claire, I think I jumped in and you were going to say something. So.
No, I was just going to ask Julie if you wanted to discuss the letters of support question.
Yes. Do you want me to? You want me?
I can kick us off. One wanted to quickly discuss is whether or not the advisory council feels that providing letters of support would fall within the scope of responsibility and authority for this body. And if so, what approval process we would have for something like that.
So Claire, this is Dr. Hildreth. What is the context of the letters of support?
So they would be letters of support to advance specifically EHE project goals. So this came up because we do have a partner who is in our trauma-informed care cultural humility project team, which is part of EHE, part of our implementation, you know, that is seeking a grant that would help fund her time to work towards, you know, helping our EHE work. And I'm seeing that there are going to be a number of these coming up in the next year. This is the first time this question has been raised, but I know there's a lot of grant opportunities that we're seeking out of the work groups going forward, and wanted to establish, you know, one, whether this council thinks that this is within the scope of the council's responsibility, and two, how you would want to go about reviewing and approving letters. And recognizing too that there, you know, are conflicts of interest within, inevitably, for example, the person who would be making this application, you know, is at Meharry, and then works with Vanderbilt and has a number of different roles. So I don't know if council members would want to recuse themselves from voting, or if a voting process would even be necessary.
This is Brian, and I guess what my question would be, is the juice worth the squeeze? I mean, if we're going to develop a process to review and all that, do these letters of support make a material difference when, you know, presumably the mayor might consider writing a letter of support, the Metro Public Health Director might write a letter of support, and each of us individually might write letters of support for our partners. So that seems like maybe a more fruitful process and would get probably more bang for the buck than trying to design a separate process here.
And Julie, when you say partners, you mean partners of ending the epidemic effort in Nashville, is that right?
Yes.
Well, I don't see that it could do any harm to have a letter from the council, but I kind of agree with Brian that it doesn't need to be an overly complicated or complex process. So I don't have strong feelings about it, but if you decide to do it, I would be supportive.
My suggestion, just based on how other kind of quasi-governmental advisory councils have approached this is if finding that it falls within the scope of your authority, if there is kind of a limited amount of time that council members have to read the letters, read what the projects that are requesting support are, and have a window of time to give comments to co-chairs, that it would be the co-chairs who would actually be signing.
I really got to come back to that. Just, I don't have time to do this, and I don't think it's appropriate for the council to be doing this. That's a distraction from what we really came together to do. And so unless there's a really overriding imperative to go down this path, I'm just not sure why we would take on that kind of distraction.
Any other opinions for or against? Okay, so maybe we table this for now. Julie, what do you think?
I mean, it really is up to the council, and it wasn't put on the agenda as an item to vote. So if you think that, tabling it would be the best way to move forward, I think that's a good idea, and then we can put it on as an action item for a future agenda, and do a little bit more work on that. I mean, I personally could see, either way, it falling within the scope of the council or not, just looking at, what the responsibility and authority there is, the direction to ensure that resources are allocated and efforts and assets are directed towards populations that have historically been disproportionately impacted by HIV. So I would think probably prioritizing, if the council were to say anything that is particularly has an equity lens applied to it, that would be a part of the rubric by which you would determine whether or not to advance this. But again, this is a council decision, so I'm neutral.
So, Julie, are there other advisory councils for which this is a practice?
Yes, and particularly because a lot of other bodies actually have ones that are established that have funding to allocate. They don't typically do that because they're allocating the funding to the organizations. This is an advisory body, which is a little bit, different and limited in certain ways because of that. But there is a precedent for this, yes.
Well, I thought that early on when we started planning the council and its activities that we would look for ways to find funding or support for programs and activities beyond what Metro would provide. So I would think that if some of these grants are germane to our efforts and things that we're trying to accomplish, if our support would help the individuals get the grants and they're consistent with our goals, then, I think it would be a good thing. But I do agree with Brian. There's a lot going on, and, there's not a whole bunch of time to devote to things. So I think there are good aspects of this or good things about it. But at the same time, there's only so much time that we have to devote to these things. But getting grants to support activities that are relevant to our goals, I think should be something we should support for sure.
So maybe Julie, you and Dr. Bullock and I can discuss what a potential process for this might look like that wouldn't, it seems like the issue here is just is time. Outside of these meetings, it's hard enough to get everybody on these meetings, right? So, and I definitely understand that just finding time to review these letters of support is going to be a burden, and we certainly don't want that. So maybe we can discuss that at our next co-chair meeting and discuss some potential ways to do this that wouldn't end up being a burden on council members, and potentially bring that to a vote at a future meeting. Okay. In that case, we are right at the hour, and I just want to wrap up with announcements. I do have a quick one, and then if anybody else has any, you can shout out. I just want to let everybody know that I'll be going on maternity leave next month, so I won't be at our next meeting, which I think is in March. So I will be leaving you in the capable hands of Dr. Bullock as your only co-chair for a little bit. Does anybody else have anything?
Well, congratulations, Claire, on your pending new arrival.
Thank you. Appreciate it.
The one thing I would like to just say to the whole group is that the COVID-19 pandemic will be over before the HIV pandemic will be. So we just hang in there, and this work is very important. We need to keep it up. So just say that.
All right. Well, thank you everybody for taking the time to be on today. Our next meeting is March 18th from 2:30 to 4. You know, probably virtually, but who knows? You know, maybe we'll be able to meet in person sometime again soon. So thank you all, and have a great afternoon.
Thank you. Bye-bye.
Thanks, everyone.
Thanks, everyone.